All right, I believe we are live right now. Good afternoon. It's September 11th, 2020. My name is Kemal Erkan. I'm the chairman of United Medical ACO. This is our weekly event. We started about eight weeks ago. This is our event number 8. So many of you by now know what we do in these. We have a small agenda, pretty topic specific. So I believe right now you should be able to see that on my screen. And all right, now today we are going to go through some of the updates from the latest on Corona, and then we are going to have Dr. Gary Singh from Delaware Cardiovascular, who's going to join us. And we'll discuss telemedicine, patient portal, and the life after COVID-19 for those patients who have COVID-19 and cardiovascular disease. Now, today, 19 years ago today, there was a big tragedy in our history, and we do want to remember those who were the first responders who protected this country. I've been here for 22 years. Most of my adult life is in this country, and I have to say, I think there is no other country in the world that is accepting the coexistings, and I'm hoping that we will never see these types of tragedies ever again. But we do want to remember those, and hopefully this will be the last. So just for those who may not be watching the older videos, United Medical have different services in healthcare. We are a full, it's almost like a full service turnkey solution. We call everything that medical practice may need in the for those private practices. We would be providing those services. Now, one of our main goal is probably most of our followers do hear the triple aim, but we want to take that to a quadruple aim. And this is one of the slides that I shared from our one of our town hall meetings, and how can we actually do triple aim without including our physicians. And I think physicians, in my opinion, in some cases, they are not getting enough appreciation, and we don't understand, or we don't see the shortage of physicians as a big issue. And I do believe that it is my responsibility as the chairman of an ACO in Delaware to make sure that we emphasize how important our physicians are. And I don't believe there can be any type of quality outcome without including our physician and physician practices, and we appreciate them once again. Just going to go over a little bit on the daily numbers. I do keep this format for our followers to see these easily from April 15th, May 15th, and as of today. As you can see, the total numbers where we were about 1 million in the confirmed cases on April 15th, we are at almost 6 million. So that's 660% more. So just to kind of show the issue and how important this is. Now, the number of deaths is almost 200,000. Now, I do remember, now Dr. Singh already joined me, and I will introduce him properly, but I do want to ask him if he remembers. I believe the 200,000, they were saying that by November 1st, we were going to hit 200,000 number of deaths. But I think it's already September 11th, and we have that number, which is, it seems like it's going to be worse than the projected number. And hopefully we can control this in the next couple of months. Now, in Delaware, our numbers are a little bit different. Now, one of the issues that we don't have enough number of tests in Delaware. And we try to communicate this issue with our local government. We are not successful, but I do want to make sure that our community in Delaware knows where we are. The numbers look good, percentages are great comparing to the other states. However, we don't have enough number of tests The average is lower than the US average. And if I don't mention the Rhode Island in any of my presentations, it would be wrong. Rhode Island, similar to our population, they are twice more than what we have in terms of number of tests in 1 million. All right, so today, as I mentioned earlier, Dr. Gary Singh from Delaware Cardiovascular, who's joining me. Now, Delaware Cardiovascular is a special organization for me because they're actually my first employer in the healthcare industry. So I was employed by DCA in May 2000. So that's 20 years ago. And then after a couple of years, I was in the business office. We had a branch out and did have the billing services and the EMR services. But DCA, Delaware Cardiovascular, still is one of our strongest supporter and client for almost 20 years since the beginning. They do have services throughout the state. In fact, they are the only private group who is providing cardiology services in every county in Delaware. From that point, it's extremely important what DCA does. We may have enough cardiologists in Newcastle County. That is not the case in Kent and Sussex counties. And again, we do appreciate our practices who are filling the gap for us because in some cases they end up providing primary care office services because there is not enough provider. Now, Dr. Singh is, DCA special, and also Dr. Singh is special for me. He's one of my very close friends. Now, actually, he's my neighbor. He's my client. He's part of our ACO. He's one of the nicest people I have ever known, and I always appreciate his friendship and his support. He is, as the president of Delaware Cardiovascular, he's going to actually talk to us about the telemedicine, and also we have specific cardiology-related questions for life after COVID for the patient with cardiac disease. So, Dr. Singh, thank you for joining us.
Good afternoon. Thank you, Kemal, for that very kind introduction. Pleasure to be here. Obviously, I haven't got my haircut since that last picture, but it'll get there at some point.
I do my own haircut now.
Yeah. I think I've got to go down that route. COVID, as with everyone else, has presented some interesting challenges for us, and the numbers you cited are quite interesting. Obviously, we're proceeding at a faster rate than had originally been anticipated. Our main concern, as was actually stated by Dr. Fauci, I believe, either late yesterday or earlier today, is the upcoming fall and winter season, when we anticipate a significant increase in hospitalizations, not just due to COVID, but also the flu. That's why there's the big push on for everyone to get the flu shots. So that's really very concerning to all of us. The risk factors for getting ill from COVID are almost, thank you for putting that up right there. Cardiovascular disease, diabetes, renal disease, which always so many times overlaps with cardiovascular disease. Obesity, again, overlaps with cardiovascular disease. And it's a large percentage of the population when you put all that together, which means a fairly sizable chunk of the population that's at risk. I mean, over 105 million people in this country have high blood pressure. So that right there is a huge number of people. So we do anticipate somewhat of a worsening, and hopefully people will tend to become more cautious in the wintertime. I just do want to touch on one thing. You mentioned the testing, and it's a really incredibly important aspect. We need to get more people tested. I will point out though that there are tests out there that I think our patient population is not always taking advantage of, that are offered for free. And these they're usually offered through Curative and State of Delaware. I myself had one at Smyrna High School a couple of weeks ago, and they still had about 380 open slots that weren't utilized. So I think we need to encourage our patients, even when we're not ordering the tests, to say, hey, you know what, even if you just are unsure, if you think you may have been exposed, if you went someplace and you're not sure what happened, there's no prescription required, there's no illness required. They can just sign up online, go get your test done, they'll send you an email, and the results are usually back within 48 hours. They've been really good about it. So, again, I couldn't agree more. More testing is really the key to controlling this at this point. But if we can encourage our patients that do as much testing as possible and tell them about the resources that are available, I think would be important, especially some of our elderly patients who may not always be aware. They're not media savvy, they don't use their email as much as they should. But I think it would be really important to do that.
Now, Dr. Singh, so for you guys, for the cardiology, this was a bigger challenge. As you mentioned, like your Medicare population is much higher than anyone else. But also the comorbidities of the patient, they don't have just one problem, they have several different issues.
Yeah.
So this was even more challenging. Now, your practice and yourself, you adopted the telehealth early on. Now, how is that going so far? Are you having any challenges? Like last week, for example, I did cover do's and don'ts of telemedicine from patient standpoint. How are you doing so far?
It has been challenging. I think just like anything else, there's a learning curve for patients as well as providers. But the biggest obstacle for us, as you pointed out, so we have a somewhat rural population. We have a decent percentage of our population that's rural, and they don't always have access to broadband. So the video aspect was somewhat challenging. And with that, it's gotten better. We have several different platforms that we're utilizing. We're using everything from DoxyMe to FaceTime to Google Duo. And some patients with Medicare, we do audio only. The limitations for us obviously are there are times we really do want to see an EKG. So we'll keeping in mind that we are still open. We always have been open in the office. We never stopped testing. Our testing is always open. Our patients are always going to need their stress tests, their echoes, etc. So we have a lot of times we'll do the session and say, hey, you know what? You've got a procedure coming up. We need an EKG. Come on and just get your EKG and leave. And obviously, it's a very safe process for the patients. Our waiting rooms are not crowded at all. Not only we space them out, most of our patients wait in the cars. They come in, get their procedure done, and then leave. But as far as the telemedicine end of it, I think I'm also looking forward to something that you had talked about, which was being able to do it through IQ Health and IQ Portal. I think that's hopefully coming up.
Absolutely. So we actually started with that in United Medical Clinic. They are completing their second week. So basically, when we have the pandemic, and we kind of reacted to the issue with telemedicine, and so every channel was available, we were able to use like DoxyMe and the FaceTime, WhatsApp, any type of video. But we want to standardize that, and we went back to our EMR vendor, Cerner, and we have a now solution that actually allows us to use our EMR through our patient portal, where we don't need to use any links or anything else, except our patient have to use their patient portal. That actually makes it a lot more better from the end user point, so that it's a much more pleasant experience. Now we are going to have one specialist group going live, I believe, next week, and after we try with them for 1 week, then we'll take everyone else, including your practice as well. Now, I'll give you that one maybe interesting statistic. So since we are doing these events more and more, we look at the statistics, and the biggest group who are following us is patients 55 and over. Mm-hmm. So, and they're through Facebook. Mm-hmm. So why I'm saying that is because there's this kind of like there's a perception in a way that if the elderlies are not able to use the technology or if they have challenges, but they are more active on Facebook than younger people. So I want to make sure that we correct that misperception so that they are using it. They do use the technology. We just need to make sure that they understand what needs to be done. And that's why actually I included this do's and don'ts, because we do have patients, in some cases, they call while they're driving, or they call while they're at the beach, or while they're shopping. So those are not okay, obviously, because we want to do this without compromising the quality. And of course, we deal with healthcare, so we cannot make any mistakes. Or of course, we may make mistakes, but we can't be set up for those mistakes in any way. So we want to make sure that we are educating our patients as well as the caretakers. Now, Dr. Singh, I do have another topic for us. So in terms of what you have seen, those patients with COVID and with cardiovascular disease recovery process and the life after COVID, have you seen anything differently on those patients? What should we be looking for to take care of those patients in the outpatient setting so that it can be more preventable?
Yeah, absolutely. And this is something we're all concerned about. Even patients who did not have to be hospitalized, but just were sick at home or were relatively asymptomatic, we know that the cardiac muscle can become inflamed. You can develop a type of myocarditis, which is inflammation of the actual muscle of the heart. And down the line, that can lead to problems with the heart, including cardiomyopathies, weakening of the heart muscle. And so what we quite often see is patients who, and actually neurologic effects too. There was recently an article, I think it came out, about long-term neurologic effects of patients who are not that ill also. And and this is only going to grow. I think as we learn more about this disease and as time goes on, and we get further and further along, we're going to see more and more long-term risks, and particularly concerning in these quote unquote, as you pointed out, asymptomatic individuals, some of whom are fairly young. I don't know what we're going to see down the line. We're already starting to see some of it. Neurologically, people are complaining of this foggy state of mind for several months. Cardiac-wise, they may have shortness of breath, and that may be the only symptom they have. So what we're recommending is if, 3 months out, you're recovered, you're doing everything else, but you're still winded, you're still short of breath, let's get that patient checked. Maybe they need an echocardiogram, maybe they need to be evaluated to make sure they did not develop a myocarditis. Perhaps they have inflammation and may have developed a pericardial effusion. There may be a cardiomyopathy. So kind of keep that high index of suspicion for these patients. If they're still having odd symptoms after supposed full recovery or having a relatively asymptomatic course, now they're popping up with symptoms that increase fatigue. Does not have to be chest pain, increased fatigue, shortness of breath, decreased activity tolerance. I think that is just not measuring up to where they used to be prior to infection. Needs to be checked out. And if it sounds like it could be cardiac symptoms, it definitely needs to be looked at because there is a significant component of it, and we're learning more and more about it, and specifically a lot of inflammation of the muscle.
Well, Dr. Singh, I do want to actually share this with you. Wasn't sure if I was going to bring this up, but because we are still investigating. So this week I have 2 cases with patients. As you know, from the surgical side, we do, before the elective surgery, we actually do the COVID testing. But we have a patient, first, actually it was on Tuesday. We find out on Monday, on the Labor Day, I was in a meeting with Dr. Erkan, and one of our patients was second-time COVID positive. Now, end of June, person was negative, and then first half of July positive, second half of July negative, and now first week of September positive again. Now, So there are a lot of reasons this could happen. It could be the false reading, false negative, false positive, but that's the opportunity almost lost there because we haven't done any blood work on these patients because just getting that information and then understanding the strain of the COVID-19 is kind of missing. Now, yesterday we had a patient, different patient from July 24th, first test positive, August 20th, I may be a couple of days off on these, positive, and then 9/7 positive. So almost like 50 days, they're positive.
Right.
Now, these two, and going back to what you were saying in terms of the COVID-19 and what happens after, still there are so many unknowns, and we deal with that many unknowns. I still have a very difficult time to understand patients not going through the testing, making sure that they know what they have, what they don't have. They don't need to be sick, honestly, just we need to test more people. But these are, some examples, like, do you have any, maybe, I mean, I don't want to put you on the spot, but other than if you take the false reading out of this, can you give us some, can you just put some light on this, why we would have these types of results?
It's an interesting question. I mean, the one thing we can say for sure about COVID is that everything we know about COVID is far, far, far less than what we don't know about COVID. So, obviously our knowledge pool is hopefully growing. It's unlike anything we've dealt with before. We do know that. The interesting about the positive, I do believe there are false negatives, obviously, but the positive that's continue, the only possibility, and I've discussed this with some people, is, we do believe there are a couple of strains out there. I mean, that's known that and then we say, well, how do people turn negative and then turn positive again? We do believe they may be getting reinfected with a different strain. We do believe that's positive. It was originally felt that the original strain was not quite as contagious, but more lethal. The second strain is far more contagious. That's the general feeling and among most scientists at this point. So I think that is a possibility. Beyond that, it's hard to say what else could be going on. Why is the infection lasting, as you pointed out, over 6 weeks? That doesn't seem to make sense because at this point, everyone else should be negative. But beyond that, we don't have a really good answer for that. As I said, I wish I could tell you more about it, but we're all perturbed about it. And the only thing they keep coming up with is it an infection is it a person who's getting infected again, potentially with another strain? And
now there are 6 total strains out there, right?
Right, but there are two big major ones that everyone talks about, and the other ones, we don't know. Again, we don't know the prevalence of them in terms of what's happening, in terms of if any of them affect the patients differently than others. Again, the state of our ignorance is far greater than the state of our knowledge.
And so the other, when we were going through these patients, I'm still working with our team here. So what I realized is that actually we don't know the strain, like the strain information is not given at the test.
Not at all.
It's something that needs to be done with the blood work.
Right.
And if we are not actually putting the researchers on the right place, getting good data, more data, I think it's going to make it even more difficult. So I actually was discussing this every time I need some more education. I come to you guys, but on the specific one, I talked to Dr. Erkan earlier this week, and he kind of went through the strain and why it would happening, what it means, and how we can actually find out. And I'm like, well, we are not doing that. So then now it's almost like if someone has those different ones, like it's almost like so much time wasted. So
we don't know.
Yeah.
It's again, unfortunately, but the only weapon we have is the testing, like we're doing. We keep testing until they're negative. But our suspicion really is they are getting different strains. That seems to be general consensus.
Yeah. So, Dr. Singh, my last one is because you mentioned it, and I did have it on my PowerPoint. I just want to kind of maybe go over this. So, what I'm just actually almost done with my latest article on the transformation that we are going through with communication. So, it's on the business, like you are right now in your office in Smyrna. I'm in Bear, and we are just doing a different meeting anymore. So we don't do in-person meetings, and then we don't do a lot of in-person visits. We do it when it's necessary, but just to kind of bring everyone up to speed and just maybe give them some, feedback on what we have seen. I prepared this list, and then I'm kind of elaborating that in my latest article. Do's and don'ts of telemedicine. We expect practices, we prepare practices in a way, but then it's not just one way. So if the patient side is not right, if the setup is not right, there will be always technical issues. So we want to make sure that our patients do follow these do's and don'ts. So because this is important, healthcare is extremely important, and we want to make sure that we are doing our job at the best level that we can. So I did want to just share this again with everyone. So now, as you know, we started promoting and doing more and more of these events, like making everyone understand what IQ Health, which is our patient portal, what it means, why we have to be using it. Now, we have also some other events, like this week, Wednesday, we have the type of bariatric procedures we discussed with Dr. Erkan from CRIAS. And then also same night on Wednesday, we have our diabetes. I believe you are going to be the next guest, if I'm not mistaken.
I believe so, yes.
I'll be on that. As United Medical ACO has the accredited diabetes organization, accreditation on diabetes, we have these twice a month events, and we are recording those videos, and it's available for public. Last week, we had podiatry and I from Brandywine Podiatry and Hosmani Eye. They covered the diabetes aspect of it, and we have today's event. Next week, we have what an individual can expect after the bariatric surgery. It's going to be on the 16th with Dr. Erkan, and there will be the same event. And this time, I have Dr. Barnett Smith from United Medical Clinic. She's going to join me to discuss the issues with the social determinant of COVID and how it's affecting different groups in a different way. And she's part of our United Medical Clinic, as I mentioned. We had her a couple of weeks ago in one of our provider meetings, and I think having the discussion around the discrepancies on how this is affecting certain groups and why it's happening and what we can do to fix those. I think the more conversation is going to be better. So she's going to educate us from that point, and she'll be our guest. Well, Dr. Singh, you are in your office seeing patients. You are in between office hours, I believe. And we really do appreciate you joining us.
My pleasure.
It is we get a lot of good feedback from our patients and our employees, our providers. And our goal is to make sure that we can make more of these events. Now, I believe my team is just signing language and me. There's a question for you. So here's the question I'm going to read. As long-haul COVID patient in Delaware, what cardiac tests would you suggest to have? Also, do you know any of the cardiac rehab facility? This is one of the questions.
Well, the cardiac rehab facility, it depends. I mean, if you've had, to be eligible for cardiac rehab, you have to have had a heart attack, a cardiac interventional procedure of some sort, whether it be an angioplasty, stent, or open heart surgery. And usually that's carried out by the hospitals. Short-term rehab, there are some facilities also that do cardiac rehab. In Dover, I know Pam does rehab. I think in Middletown Health South, I think, has facilities. I'm not sure in Newcastle who's
in
doing it.
Newcastle, Dr. Hosmani has Mid-Atlantic rehab, cardiac.
Okay.
He has it with Dr. Deliri. They're
Okay.
partners. So, yeah.
Yeah, they are available. As far as cardiac testing specifically for COVID patients, I think the thing to do is, we have seen COVID patients have heart attacks in the hospital because it's a clotting disorder, as we all know. So if it's a clotting disorder, we're going to have blood clots going to the coronary arteries as well as going to the lungs and so on, and the brain. So we've seen strokes. So obviously, if that's something acute, we will follow up afterwards, after the heart attack and the COVID infection is resolved. We'll get them through the acute medical phase and take care of that in the hospital, whether it be a cardiac catheterization, we'll do the echo, etc. However, the more difficult, that's easy. The more difficult patient is the one who has the COVID infection, stays at home, doesn't really get terribly sick. And what do we do with them? And again, I'll reiterate what I said earlier, which is talk to them about their symptoms. And if they feel 100%, they feel fine, then I don't think there's anything that we really need to rush on. However, if they do complain of symptoms that they're not feeling quite right, they're feeling fatigued, as I said, just they can't get back to their normal activity because they just overall have decreased activity tolerance. They get winded more quickly, which is what a lot of people complain about. I can't do what I used to do. I used to mow the lawn. Now I get tired mowing the lawn. I can't go for a walk like I used to. I get tired halfway there. Any of those symptoms, obviously any sort of chest discomfort, if it involves, whether it be pleuritic, meaning you take your breathing and it hurts, or if you have chest discomfort with activity, any of those symptoms, I would have a low threshold for a cardiac evaluation at that point, because we know that it affects the heart. So we have to keep that in mind.
All right.
And the other thing, just as last word too, we try to, and I know you brought it up too, but again, we try to encourage all our patients to use IQ Health as much as possible, because it makes life so much easier for them, and they're able to get their results. I think one of the biggest complaints across the offices I always hear, no matter who I talk to, is patients saying, I want to call back about this. They may not get the call back when they want it. If they go on the IQ Health, they're getting their lab results, they can make their appointments, they can get their prescriptions, leave messages, as long as they're not urgent messages, and hopefully telemedicine too.
Yeah. Well, again, thank you so much for joining us, and this was a very enjoyable session for me as well. So we'll see you soon.
Absolutely. It was my pleasure. Thank you so much.
Thank you. Thank you, everyone. We'll see you next week.
Bye-bye. Bye-bye.